For those of you who are standing up in the back, you can sit on my right-hand side over here. Because this meeting's probably going to last a minute or two. We're going to get started in just a second. We've got a quorum. No. I got a sign-up sheet right here. They had to sign up by 12 o'clock.
Okay, just trying to help you.
Yeah. They had to sign up by 12 o'clock, and if anybody was going to do it, remember they had to do it by 10. What's his name?
Which one?
Standing up
in front of
there. Yeah.
Todd Jones.
John.
He's an attorney nobody knows about.
Yeah.
Very bright. My vice chair. Sharon's here.
Okay, folks, it's if you were at my insurance committee, we may have been finished by now. But I like to start on time, and we've got a quorum and just added to it. And we're looking at Senate Bill 106. I'd like to give you a little ground rules first. You know, this is a very important issue. When you start looking at health care, you know, it's critical for the physical and financial health of everyone. So, you know, we've got to do a good job in maintaining our health, and you know, the Rural Development Council did an outstanding job in identifying some of the issues that it relates to health care, especially in the rural areas. But you know, I really foresee that this session, next session, and potentially the next 2 or 3 sessions, we're going to spend an awful lot of time on health care, because it is very critical when you consider you have so many counties that don't have any health care at all. It's kind of like a health care desert. So, but today we're looking at Senate Bill 106, and I'm going to ask Senator Tillery if he would like to make his presentation, and after that, it will be open for questions from the committee. Now, also, after Senator Tillery makes his remarks, we do have several people who would like to comment. I request that you leave your comments to 5 minutes or less. If somebody's already said something, don't want to have a repeat. And if you agree to it, just stand up and say, I agree. But if you have an issue, we're wanting to listen. As far as amendments are concerned, the only ones, and I've seen, the requirement was all amendments had to be in my office by 10 o'clock this morning, and as of so far, no amendments have been dropped. We've had a proposal for a complete change in the legislation, but it was not drafted in amendment form, and only those in the committee can drop an amendment. So I'm going to turn it over to the senator and let him make his presentation. And by the way, Representative Lott, I understand, will be carrying this bill in the House once it clears this committee, once and if. Thank you, sir. Go ahead.
Thank you, Mr. Chairman. Thank you, members of the committee. I bring before you Senate Bill 106. I think it's your LC number 337678EC. It's a very simple bill. As I said when I presented this on the floor of the Senate, a very simple bill, 3 pages that could have far-reaching effects for the healthcare in Georgia. It's very simple in its concept. It provides the ability for the state to apply for 2 waivers. The first would be a waiver to Section 1115 of the Medicaid Act. The Medicaid Act was first passed by Congress in 1965. It's a very rigid act. It's structurally strong, and if you take and do anything different from what that original act says, you have to ask for an amendment, and those amendments we call waivers. They're not necessarily new. I believe Georgia has about 11 of them so far. One of them you may have heard about that we are in the process of applying for a new waiver for right now is the Planning for Healthy Babies. So these aren't necessarily new in concept. What this waiver would do, though, is slightly new in concept. It would allow us to take and provide some type of innovative procedures and innovative ideas to, for the first time, put some type of restrictions on what we're doing with Medicaid. We may those can come in a variety of different forms. They could potentially be work requirements. They could be some type of inclusion that requires that we incentivize primary care. But it's looking at a program that many of us in this room feel is currently not working the right way, whether it's not working the right way for patients or for providers, and providing some changes that would make that current system be feasible for hopefully for years to come, and also incentivize behaviors to lean those behaviors towards more cost-effective ways to provide health care. The second part of this bill is a waiver to Section 1332 of the Affordable Care Act. The Affordable Care Act right now, a waiver on Section 1332 could potentially look like a high-risk pool. It may also look like a high-risk pool. So what we could do is go into certain programs that are costing us a lot right now on insurance policies and allow those individuals to be pulled out and treated differently. They wouldn't see it. It would be invisible the way the pool would potentially work. But we could use that program to drive down the cost of health care insurance for those who are buying health care on the private market. Right now, I'm sure you've seen it in your district. I've certainly heard it in mine, that we have folks who are paying 2 and 3 times the amount of their home mortgage on health care insurance monthly premiums. That's not even talking about the co-pays or the deductibles. And what this Section 1332 waiver would allow us to do is to try to drive down that cost of monthly premiums for hardworking Georgians so they would be able to afford health insurance if they were above 100% of the poverty line. Simple bill in its scope, simple bill in its wording, but again, Mr. Chairman and members of the committee, very far-reaching in what I think it can help us accomplish for hardworking Georgians. If there are any questions, I'll certainly yield to those.
Thank you, sir. Your comments then about people who are paying extremely high premium rates. I talked to a young man last summer. His wife had a baby, and the premiums that he would pay just for his wife and child would have been higher than his mortgage. And if he added himself to it, it had been another payment higher than his mortgage. So the price of health care is killing us. So anything that we can do to lower the price of health care, I think we need to take a good, hard, close look at it. Now, does anyone on the committee have a question for the senator? Okay. Seeing none. Thank you, sir.
Thank you.
We've got some folks who are wanting to speak, and I want to apologize up front if I mispronounce your name, because I'm sure I will, because just looking through this, some of your handwriting is no better than mine. Matter of fact, some of it's even worse than mine. Okay. Dr. Rutledge Forney, okay. At least I can read your writing. I can't pronounce it, but I can read it.
Unusual for a physician.
Yeah.
Thank you to the members of the committee to hear me today. On behalf of all the physicians of Georgia, I want to enthusiastically thank Governor Kemp for his leadership on this issue and Senator Tillery for bringing the legislation forward. Expanding access to care to the citizens of Georgia has been a legislative priority for the Medical Association of Georgia for the past several years, and it remains a priority this year. MAG policy calls for MAG to support a Medicaid waiver to close the coverage gap in Georgia in a fiscally responsible and sustainable way that meets the needs of patients and physicians. This waiver should assure that patients receive proven, cost-effective care that is not impeded by unnecessary barriers to enrollment or unaffordable cost sharing. The waiver should also eliminate regulatory barriers to proven cost-effective care and seek parity for all physician services with the Medicare fee schedule. We also support a waiver from HHS to allow Georgia to use the Medicaid expansion funds to buy private insurance in the state health insurance exchange for eligible citizens. We are very pleased that this issue is in the spotlight. We are ready to help in any way we can. And again, we want to thank Governor Kemp for his leadership in bringing this forward and giving us an opportunity to move forward. Thank you very much.
Thank you, ma'am. Let's see, next on the list is Faye Fulton from the Georgia Academy of Family Physicians. And who's on deck is Matt Hicks from Grady Health System.
Thank you, Mr. Chair and members of the committee. My name is Faye Fulton, and I run the Georgia Academy of Family Physicians. We have a letter that is in your folder related to our support of this bill, and with the remainder of my time, I'd like to cede it to one of our board members, Dr. Lee Church from Hiawassee. Dr. Church.
Thank you for letting me be here today. I'm from Hiawassee, which is the very tip top of Georgia and not quite one of those deserts, but close for healthcare resources. It's a healthcare shortage area. I've been in there for 16 years, and I practice in the hospital and the office. I teach medical students, one of whom is with me today. I'm embedded in the community deeply. You know, having better access to health care is important to all of us as in a policy, but as a practical matter for my patients. Like most communities, there are a lot of folks that don't have insurance or insurances that is just really burdensome from the deductible standpoint. And I have a provider shortage, which is its own access issue, but there are some other basic insurance issues that all but assures that patients don't receive preventive services or they delay their care until there's a crisis. One of those crises happened just last week with one of my patients who had a hand infection. He works, he has a high deductible, and he didn't want to go to the emergency department to save money and deductibles, but his hand was so infected that he nearly needed to be hospitalized, and as a result of that delayed care, missed a week of work because of that, and that just shouldn't be happening. So a healthier community is good for all of us. It's also good for the economy, not because of more spending on health care with healthcare dollars, but because people aren't missing work, and there's missed school that's avoided, et cetera, and avoidance of hospitalizations. I know there's no amendments that are open, but I would, if there's any possibility to expand that coverage to 138% of the poverty level, folks like my patient probably could still work and be covered as well. I appreciate your time, and I'll be open to any questions you might have.
See no questions. Thank you, sir. Okay, Matt Hicks from Grady Health, and then Julie Wyndham from Navicent.
Good afternoon, Mr. Chairman, members of the committee. Thank you for the opportunity to testify in support of Senate Bill 106. As you know, Grady is Georgia's largest hospital and one of the nation's largest trauma and safety net hospitals. Every day, Grady serves some of Georgia's most vulnerable residents. Last year, Grady had nearly 700,000 patient visits and served Georgians from every county in the state. Approximately 30% of our payer mix is uninsured, and in 2017, we provided over $304 million in uncompensated care costs. We see Grady as a place of solutions, and one of those potential solutions is a waiver that could help the uninsured patients we serve. Many of you have probably heard Grady has been encouraging a waiver conversation for more than 5 years now. And I want to explain why Grady supports a waiver and why we hope you will too by passing this legislation. First, waivers are an important tool in your tool belt to address the healthcare needs facing the state. We're grateful for you and all of your colleagues who participated in the more than 20 legislative study committees that met over the last 2 years and all of the follow-up meetings that occurred because of them to discuss in one way or another the healthcare challenges facing the state. The list of challenges is long, so I won't repeat them, but what we heard in those hearings and meetings was a call to transform how we deliver care to the uninsured. Waivers will allow Georgia to apply for and receive flexibility and resources from the federal government to design healthcare solutions that meet the unique needs across our state. While we would like to think we can do it alone, we must partner with the federal government to make progress. The second reason we support waivers is because of Grady's story and because of our patients. As most of you know, Grady almost closed its door just over 10 years ago, and I'd like to pause to recognize that several of you in this committee were here in 2008 and contributed to saving Grady, so thank you. One of the other keys to our successful transformation has been the support we receive from Georgia's philanthropic community. The philanthropic community funded a number of projects at Grady, from a walk-in center across from our emergency room to patient navigators within the health system. Eventually, several of them came to our leadership and said, while funding these individual projects is important, we need a more comprehensive approach to caring for the uninsured. We formed a working group of philanthropists, FQHCs, some of our own providers, and others. The group studied what states across the country have done, and that is when we learned how states have used 1115 waivers to accomplish many things. From delivery system reform, where states incentivize better quality care and collaboration between providers, to payment innovation, such as putting providers at some risk for achieving outcomes, to increased Medicaid coverage, and more. We saw great examples of how waivers can combine increased coverage with delivery system and payment reform, leading to better health outcomes and reduced costs. We also saw this could apply to rural and urban areas. We took those learnings, and since a waiver wasn't possible at the time, we started implementing what we could in a limited fashion with grant funds. And in our view, those projects have become proofs of concept for what Georgia could accomplish through a waiver. One example is the chronic care clinic that we established just over a year and a half ago, where patients that come to our emergency room 6 or more times a year are met with a care team that takes a holistic approach to their care, addressing not just their clinical needs, but the social determinants of health, such as housing or access to food, and gets them to the right care at the right time and right place. We believe we could scale that approach with a waiver. And for these reasons, Grady has supported an 1115 waiver approach over the last 5 years. We believe the time is now. Georgia needs these waivers, and we ask you to give a green light to improve access to health care in Georgia. Thank you.
Thank you, sir. Any questions? Seeing none, okay. Julie Wyndham is on next, and Deb Bailey is waiting in line.
Thank you, Mr. Chairman. Unfortunately, Deb Bailey had to go to another committee meeting, but
Okay.
she asked me to let you know that she supports the legislation. So Thank you, Mr. Chairman, members of the committee. My name is Julie Wyndham. I represent Navicent Health. We are a 5-hospital system in central Georgia, headquartered in Macon. And we support the waivers contemplated in this bill for 2 reasons. First, we believe it will increase access to coverage for the uninsured, both through the Medicaid program and through the increased use of the exchange programs. And that's important to us, particularly at Navicent, for 2 reasons. First, since the ACA passed in 2013, we have seen a $207 million reduction in federal reimbursement straight to our bottom line. So we believe that increasing access to coverage will actually help mitigate those losses going forward. And the second reason we support increased access to coverage is because we once again this October are facing the loss of Medicaid DSH funds at the federal level. We've been successful in getting those cuts pushed back for a number of times now, but if we're not, again, having increased access and more coverage will help offset those losses should we not be successful stopping that at the federal level. But perhaps most importantly, we support these waivers because we see it as a way, as Mr. Hicks mentioned, to transform the way we provide care through the Medicaid program. And I'll give you just an example of something we're doing in Macon Bibb that we think would be beneficial to consider for these waivers. We have a partnership with our federally qualified health center, First Choice Primary Care, in our area, and working with them over the past year, we've identified 1,700 Medicaid patients who are high utilizers of our ER. And since that time, by getting those patients the primary care they need and getting them into a patient-centered medical home at that FQHC, we have seen a greater than 50% reduction in ER utilization, avoidable admissions, and avoidable readmissions. And that's not only saving money for the Medicaid program, but it's making those patients be able to stay at home with their family, continue to go to work and live their lives and not have to be in the hospital. So we certainly applaud the governor and his floor leaders and his staff for working on this, and we would appreciate your favorable consideration of Senate Bill 106. Thank you.
Thank you, ma'am. Any questions for the lady? Okay. Chairman Cooper.
Julie, thank you very much for mentioning our federally qualified health programs. We have 225 of them across our state. Only 35 of our counties don't have them, and they are working and giving excellent long-term outpatient health initiatives and being successful. So thank you very much for mentioning them. I'm glad y'all are using them with Navigate.
We're seeing great benefits from our partnership with them, so we would encourage increasing that.
Well, they provide a tremendous service. Okay, Laura, is S-H-A-R-K-E? Okay. And then Elizabeth Fullerton, waiting in the wings.
Thank you, Chairman Smith and members of the committee. I am Laura Harker, and I serve as the policy analyst at Georgia Budget and Policy Institute, where I research the healthcare budget and related policies. SB 106 takes an important first step towards a healthcare coverage solution in Georgia, but with some improvements, a small change could be made to allow the governor and the Department of Community Health to explore all of the possible Medicaid 1115 waiver options to improve healthcare in the state. Every Medicaid waiver state receiving the 9-to-1 federal match, including Kentucky, Arkansas, and Indiana, has extended their income threshold up to 138% of the federal poverty threshold. Capping the income limit at 100% of federal poverty could leave the state paying more while seeing a smaller drop in our state's already high uninsured rate. And at 100% of poverty, we would be taking the risk of only getting 67% of the costs covered by the federal government compared to a 90% match that we could get, as other states have done. Wisconsin is one example of a state that has capped their income threshold at 100% of poverty, and they did not receive the 90% match to do so. And a study found that looking at if they moved up to 133 or 138% of poverty, 80,000 more people would have been covered at a net savings of $190 million per year for the state's taxpayers. And all of the neighboring states increased their Medicaid eligibility up to 138% and saw much larger drops in their state's uninsured rates. And there's some uncertainty at the federal level around guidance, and even if guidance were to take a big change and allow an unprecedented deal for our state, Georgia could end up creating a new kind of gap that does not exist in any other Medicaid waiver state. And this would include the Georgians who make between 100 and 138% of poverty, about $12,000 a year to $17,000 a year for an individual. And they would have to pay more money out of pocket on the marketplace compared to if they were able to enroll in Medicaid. And even though marketplace subsidies are available to those who make between 100% and 400% of poverty, Georgia still has about 230,000 people making between 100 and 138% of poverty that are still uninsured. And we should not continue to make the cost of health coverage a barrier for this group to access health services that they need. And given the uncertainty about the cost of this proposal and no fiscal note provided along with it, as well as the higher out-of-pocket costs that people near the poverty line could end up facing, Georgia Budget and Policy Institute recommends that SB 106 provide full flexibility for the Department of Community Health to submit a waiver that goes up to 138% of the poverty line. Thank you.
Okay, Chairman Reinders has a question.
Thank you. So the Nonpartisan Budget and Policy Institute, as this bill is written, is opposed.
We do not have an official position on the bill. We are providing recommendations for
I know you want
improvement.
more, but I'm asking you, is yes or no, is Georgia better off like we are currently today, or if this bill passes?
We would like to see a waiver that extends coverage to people in the state.
I understand, but my question is Georgia better off today than if this bill passes?
Our position is that we would like to see improvements to the bill.
Can I ask it one more time?
Yeah. No, just. Okay. Thank you, ma'am.
Thank you.
Oh,
Okay.
Chairman Cooper.
I mean, I understand what you said. Excuse me. No, it's all right, and I'm not going to badger you. But I will tell you, I understand about, the reason to going up to 138%. I will tell you that the president last week indicated that he was going to change that so that states not going to 138% would still get the 90% rate. Of course, nothing is written in stone, and it hadn't happened yet, but there is hope if this passes like it is, that it will go up.
Yeah, and that's why I think that thinking about the people between 100 and 138, just the affordability aspect of how it would compare to other states, that population is
I understand.
a concern.
Thank you.
Thank you. Any other questions?
Nope, don't see any. Thank you, ma'am.
Thanks.
Okay, Elizabeth Fullerton with,
NAMI, Georgia.
Neil Campbell?
So, excuse me, sorry. I'm Elizabeth Fullerton. I'm the new Associate Director of Policy and Awareness with NAMI, Georgia. We're the National Alliance on Mental Illness. We're the Georgia chapter. So I'm here to advocate and to thank you all for all that you are doing with this conversation and opening it up to expanding insurance and health care here in Georgia. At NAMI, we seek to serve all who are affected by mental illness and help them find hope, help, and acceptance. We work with multiple groups across the state, from everyone from families to individuals to peers to veterans to providers to first aid responders to college students to law enforcement. And we try to just make certain that everybody's needs are met in the state. So first and foremost, my main comment here today is that on behalf of all of the public policy folks that work on mental health here in this state, we applaud you and we thank the governor and we thank the senator for taking these first steps and beginning the conversation to talk about Medicaid expansion. We do advocate that if it is at all possible to add in the 138%, just to give Georgia the best possible ability to have that flexibility. But we also understand that we want to start this conversation. We want to be a part of it. And so anything we can do to help you guys out to expand that and to make certain that more folks in Georgia are covered, we're here to help. So thank you again, and I'll ask for any questions.
Anyone have any questions for the lady?
Just tell her thank you for all that NAMI does.
Thank you for all that NAMI does.
She's good. She's enjoying being my mom is former state representative Carol Fullerton. So, but yeah, she's good.
Okay, thank you, ma'am. Let's see. Campbell? Neil, okay. And then Michael Cortez is up next.
Tall girl. Good afternoon, Chairman Smith and members of the Access to Quality Healthcare Committee. Thank you for the opportunity to speak with you today, and I'd like to thank Senator Tillman and Representative Lott for carrying this legislation forward. I'd also like to thank Governor Kemp for his efforts to support recovering people in Georgia. It says a lot that both Governor Kemp and the Georgia General Assembly are leading on this important healthcare issue. My name is Neil Campbell, and I'm the Executive Director of the Georgia Council on Substance Abuse. We're a nonprofit organization, and our mission is to increase the impact of recovery in our communities through education, advocacy, training, and peer recovery support services. I'm also a woman in long-term recovery, and what that means for me is that it's been over 28 years since I've had my last drink or illegal drug, and I speak out about my recovery because I think everybody should have the opportunities that I've had to get and to stay well. Ours is a community in crisis. Our peers are dying at record numbers, and we are their voice. We think that Senate Bill 106 can play a critical role in Georgia's ability to provide its citizens with the opportunities to get well and to stay well, too. And I'd like to begin by thanking many members of this committee for your efforts over the last 3 years to address the opiate overdose crisis that's been harming individuals, families, and communities throughout our state. Between 3 and 4 Georgians are dying every day of overdose. For the first time ever, the annual deaths of overdose exceeded the annual deaths of car crashes. That's unacceptable. But you have created and strengthened the prescription drug monitoring program. You've provided funding for babies with neonatal abstinence syndrome. You've provided 16 communities with local, peer-run recovery resources, and you've supported efforts to increase services and supports to our returning citizens, many of whom have struggled with substance use disorders, mental illness, or both. Even with your positive efforts, however, our communities continue to seek solutions to not only the current overdose crisis, but to the scourge that substance use disorders bring to bear on our communities. By providing an individual with the crucial first step of affordable and accessible health insurance through expanded coverage, communities can increase opportunities for families and help them live healthier lives. Just like people with other preventable, treatable, chronic health conditions, people with addiction need access to a broad range of services and supports. Expanded coverage to the poor and nearly poor in our state can provide people with the individualized and comprehensive care that they need. Preventing drug and alcohol problems before they begin is an important long-term strategy to combat addiction. Closing the coverage gap would increase prevention for many of the most vulnerable people in our state, including our youth. If youth and their families can access routine primary care, early substance misuse can be detected and treated before significant problems developed, an opportunity I didn't have as a child. Traditionally, we have used temporary, earmarked funds for addiction treatment, and this does not replace people providing people with insurance coverage, which allows them to seek care as needed, including care for mental illness and physical health issues that often accompany those of us with substance use disorders. Effectively addressing addiction requires comprehensive approaches to coverage, treatment, and support services. The number one cost to all businesses is employee retention. An investment in care of this sort on the front end is actually a pro-jobs investment on the back end. In order to remain the number one state for business in this country, we have to make our workforce stronger. We need healthy workers all over the state to do all kinds of jobs. People who get into recovery demonstrate that they can improve their lives by getting and staying employed. They live healthier and they demonstrably commit less crimes. Currently, approximately 70% of all jail inmates, 50% of inmates in state prisons have a substance use disorder. Since people returning to their communities from incarceration are at high risk of drug overdose, connecting them with health insurance can be life-saving. Providing access to care and treatment can be a deterrent to reoffending. States that have expanded Medicaid have seen their uninsured rate for formerly incarcerated people drop by 10%. The opioid crisis is a public health emergency that will not be reversed overnight. Addiction is a pervasive issue in our state, but it can be prevented and treated. And please remember that recovery is not always linear. Health coverage is part of an important continuum of care that can support long-term recovery. Georgia can take an important and necessary step to stem the tide of this crisis by expanding coverage and providing life-saving health coverage to tens of thousands of residents. I thank you for your time, and I'm happy to answer any questions.
Okay. Seeing none. Thank you.
Okay. Thanks.
All right. Okay. Identify who you are and who you represent.
Sounds good. Thank you, Mr. Chairman, members of the committee. My name is Michael Cortez, and I represent the American Heart Association here in Georgia. The first thing I'd like to say is, again, thank you to Senator Tillery, Representative Lott, and Governor Kemp for bringing this piece of legislation forward. I think, like many others who have gotten up here before me to speak, this represents an important first step to increasing access of care in our state. With that being said, it is the position of the American Heart Association that we'd obviously like to see the coverage threshold increased to 138% here in the state. And without being duplicative and mentioning things that others have, I'll get into maybe the specific reasons why, as an organization focused on heart health, that's important to us. So as you may or may not know, cardiovascular disease is the single leading cause of death in Georgia, and it accounts for around 20,000 deaths a year, which is about 1 in 3 deaths and is about a 6% higher rate than the rest of the country. And Medicaid is already an important source of coverage for patients with heart disease, stroke, and other cardiovascular diseases. And by expanding that coverage threshold up to 138%, it becomes an even more important source for coverage for currently uninsured adults or adults who are at risk for CVD. And here in Georgia, we are experiencing around a 33% rate of adults who have hypertension, which amounts to about 1.6 million people. When we talk about cardiovascular disease in general, we're looking at about, in 2010, it was about 460,000 individuals, and it's estimated by 2030 that'll reach well over 2 million. So we've seen that states who have increased their thresholds up to this amount have markedly less uninsured adults who are at risk for CVD, as well as less uninsured adults with a history of heart disease or stroke when compared to states who haven't. From a preventative perspective, increasing the coverage to this threshold represents an important safety net for Americans who are living with cardiovascular disease. Currently, 28% of the adult Medicaid beneficiaries have CVD or cardiovascular disease, and further increase of the threshold to that 138 percentage would provide positive effects for those individuals who are currently living with these challenges. From a federal perspective, if every state in the country were to expand their coverage up to 138%, we would see a treatment rate among adults with hypertension increase by 12.1%. There would be a reduction of 485,000 cases of coronary heart disease, 266,000 cases of stroke, and 513,000 cardiovascular-related deaths would decrease. And that sort of expansion or increase in all of those states would result in an additional 53 million adults with pre-hypertension benefiting from early interventions that would further reduce the number of cardiovascular-related deaths in the country. Keeping all that in mind, we do recognize all the hard work that you all are doing in this, and that many of you on the committee have contributed to reducing the rates of stroke, increasing access to care, promoting healthy lifestyles, and we're appreciative of that. And again, we want to thank all of you, and we recognize this is maybe a first step towards something bigger. And if there is any way possible, we'd of course love to see that threshold increased. But with that, I will thank you for your time and answer any questions you might have.
Does anyone have a question? Okay, very good. Thank you, sir.
Thank you all.
Okay. Bernetta Haynes? Bernita, okay, I'm sorry. I apologized before we got started, remember? And,
most people get it wrong the first time.
Okay, and Laura Corbett, I think, is next.
All right. Thank you, members of the committee. I'm Bernita Haynes here from Georgia Watch, a consumer advocacy organization, here to talk about healthcare affordability issues for Georgians earning between 100 and 138% FPL. You can also refer to your handout, cost of coverage for near poor Georgians, as I'm speaking. So healthcare is expensive. We all know that in this room. Even worse, many Georgians make too much money to qualify for Medicaid, but too little to pay for either private health insurance or to qualify for financial assistance to purchase health insurance. Others are then excluded from Medicaid simply on account of being considered able-bodied adults. For these Georgians who are low-wage earners, veterans, parents, spouses, affordable health care is simply out of reach. Georgia Watch supports closing this coverage gap by expanding Medicaid coverage to all Georgians below 138% of the federal poverty level. Yes, the ACA marketplace provides a pathway for coverage for many Georgians. However, for low-income and near-poor adults and families, Medicaid provides a better coverage option. How? It better protects their finances and increases their access to care because they do not have to worry about out-of-pocket costs when they need care. You'll see on the handout that, for example, an individual family at 125% FPL with coverage in the marketplace can end up spending as much as 18% of their annual income. That's $5,000 or more on health care coverage for a family of four earning just $32,000 a year. That's over or nearly $3,000 spent on a year for an individual earning just $15,000 a year. So that's not affordable for folks in this income bracket. By extending Medicaid coverage to all individuals and families at incomes between 100% and 138 FPL, Georgia would help them spend less money on health care and more money on everyday essentials like rent, groceries, utilities, emergency needs like home and car repair, you name it. By not increasing access to those individuals, over 230,000 Georgians or so will remain uninsured because of their inability to afford private coverage. Again, these Georgians are veterans, family of veterans. I'm a veteran spouse, for instance. They are young adults, low-wage earners who work in jobs like construction, food service, childcare. For these reasons, Georgia Watch supports expanding Medicaid coverage to all Georgians below 138% of the federal poverty level. I want to thank you all for your time and open it up for any questions.
Okay, see no questions. Thank you.
Thank you.
Okay, what is that?
Corbett, Linda Colbert.
Corbett? Yeah. Oh, okay. Yeah, your writing's worse than mine. And Jimmy Lewis is next.
Good afternoon, Chairman Smith and members of the committee. My name is Laura Colbert. I'm the Executive Director at Georgians for a Healthy Future. We represent healthcare consumers across Georgia, and we work to build a future where all Georgians have access to quality, affordable healthcare that they need to live healthy lives and contribute to the health of their communities. First, we want to thank Governor Kemp, Senator Tillery, and Representative Lott for all of your work on this bill, as well as Mr. Fullenweider at the Department of Community Health. We are very excited that this conversation is moving forward. We appreciate the open door that we've had with your teams and the ongoing dialogue that, with us on this issue. It's been a really constructive and useful process, and despite disagreeing on one or two specifics in this bill, I think we've gotten to a good place of understanding. Like my colleagues before me, Georgians for a Healthy Future agrees with the goals of this bill, and we are pleased at the prospect of meaningful coverage for 240,000 Georgians who live below the poverty line. We are, however, struggling with consternation about the 200,000 or so uninsured Georgians who make just above the poverty line and may remain uncovered by the bill as it's currently written. We know Georgians with insurance coverage are healthier, they're better able to go to work and to go to school, they have less medical debt, better credit scores, and have healthier families, among many other benefits. While Georgians below the poverty line are sure to reap these benefits after gaining coverage, those just above it may miss out on those same benefits if SB 106 is not amended or other provisions are provided for those families. Again, like our colleagues at Georgia Watch and those before them, it's clear that many near-poor constituents are going to continue to face significant cost-related barriers to health care, even with the ACA's financial assistance. While Georgians in this income range can afford more than those below the poverty line, we consider it unrealistic to expect them to pay as much as 20% of their $14,000 annual salary or a $30,000 wage for a family of four just for health care. An investment that large for families already barely making ends meet essentially keeps them locked out of the healthcare system, only experiencing the benefits of coverage in emergency situations. The financial protection and access to care provided by Medicaid can better serve as the stepping stone for these families to climb into Georgia's middle class. That's why we recommend, as our colleagues have, that the committee amend the bill, if it is at all possible, to expand eligibility to 133% of the federal poverty line and cover more Georgians for fewer state dollars. Georgia is at the table now, and we have the opportunity to get this right for all Georgians on the first try. We also recommend considering removing the exact income limit altogether so that the bill is silent on the specific income limit, providing the state with flexibility to negotiate the waiver specifics that work best for Georgians and for Georgia's budget, especially in the likely situation that CMS is unable to provide the enhanced match for a partial expansion. Briefly, I just want to touch on the second part of the bill concerning Section 1332 state innovation waivers. A 1332 waiver to establish a reinsurance program would help thousands of Georgians by reducing insurance premiums and attracting more insurers to the marketplace. GHF stands in support of such efforts. However, the legislation as currently written is quite broad, and that leaves the door open to many more changes, some of which could be destabilizing to the marketplace and could jeopardize access to care for Georgians purchasing individual and small group coverage. We recommend that the committee consider whether as an amendment or an informal input to the executive branch, consider providing some recommendations to help narrow the scope of potential 1332 waivers, either specifically to a reinsurance waiver or developing a set of criteria that waivers must meet to ensure that consumers are not put at risk. We've developed 4 of our own criteria, which are on the back of the handout that we provided, and we believe that those would protect consumers but also provide enough flexibility to the state to innovate and create a stronger marketplace. We appreciate your consideration of our suggestions and hope that we can act as a resource for the state as it develops these waivers. Thank you for your time and your efforts on behalf of all of the healthcare consumers in your district. I'm happy to take any questions.
Do we have any questions for the? Okay. Chairman Cooper.
Okay, thank you for your presentation. I want to assure you that too many of the members of my caucus in the legislative body have pre-existing illnesses, so you don't have to worry. We will not be supporting a plan that does not cover pre-existing illnesses.
I appreciate that and hope that we can hold you to that.
and I'm sort of being funny saying that we all have pre-existing, but that is an imperative for us.
Wonderful. If I could just add one quick note that I forgot to mention. In the absence of an amendment, we would ask this committee to consider if the state could provide any other financial support for families and individuals making between 100 to 133% FPL who might remain in the private insurance marketplace. Again, looking at that affordability data, we think that additional financial support would go some way towards helping those families have meaningful access to care.
Okay. Thank you, ma'am.
Thank you. I appreciate it.
Chairman Cooper, what kind of pre-existing conditions do most of us have? Some of us are really serious up here.
Keeps me from disclosing.
Okay. All right, Jimmy Lewis.
Good afternoon, Mr. Chairman, committee, Senator, people in the audience, and all people interested in rural health care from where I come. My name is Jimmy Lewis, and I represent about 50 rural hospitals. I've traveled with you for the most part for the last 2 years all over the state of Georgia. Many of you have ridden with me in my very small Explorer, and we've sat close together for many miles, and we've looked at the issues, and we find ourselves too many times looking at issues that we just can't get to a solution for. And we want to rise today in support of SB 106, and we want to thank the governor for being bold enough to go after this, because I'm going to tell you a couple of stories. And when I tell you the story, it's going to blow your mind in justification of why we think this is so important. First of all, to put into perspective the trolling that we have in rural hospitals from which I speak. I was dealing with a rural hospital just 2 weeks ago who called me and had a problem. I said, how big a problem do you have? He said, it's a pretty big problem. I said, so put into perspective how big it is. And he said, well, I'm out of cash. And I said, I understand that, but I mean, sometimes we're out of cash and sometimes we're really out of cash. And he says, well, I'm really out of cash. I said, so put dollar numbers on that for what it is. He said, well, I've got less than a day and a half cash, and I'm a $15 million net operation. and I got to find some way to solve this problem. We went to work to help him solve the problem. This happened to be a hospital that had an interesting situation as to how he's paid. We talked about that a little bit, and then he said we need to work on that. What can we do? Now, I want to tell you an interesting thing that's about rural hospitals and payment. You probably have never heard of this, but and the reason the bill is so important, it'll enable this governor to go after new and better ways to do stuff. My daddy always said, if you always do what you always did, you'll always get what you always got, and that's kind of the way it is in the rural healthcare world. So in this particular hospital situation, we were trying to improve. Now, I'm a process improvement person from years ago, and you can tell it's been quite a few years ago. But nevertheless, we got into a situation where we could make an improvement in a hospital, and we could produce significant results to the bottom line to help that hospital, but we couldn't do it. And the reason we couldn't do it is because there's this federal rule out there about reimbursement called the cost of charge ratio. And in the cost of charge ratio, what happens if you do real good, you get to give it all back at the end of the year. Now, I know that sounds crazy, and it sounded crazy to me. The first time we went through that calculation, and I had a hospital down in deep South Georgia, we did significant improvements to the tune of about $600,000. It came down through the end of the year, and the auditor said, you really did good, and 60 days later they said, you did so good that because of this rule you got to give it all back. And so we had to give it all back. And we've done that time and time and time again. And the reason is because we can't find a way to get around the rule to help us get around the rule. The reason this concept of waivers like this, 1115s and 1332s, it's about finding a better way to do things. And right now we don't have a better way to do things, and we've got to have that better way to do things. Had another story, and you'll find it kind of interesting. It was mentioned earlier about frequent flyers. Well, we did some work over the last 4 years. We're doing all kind of improvement projects out in the world, and we kept working with frequent flyers. And frequent flyers are those people who show up in the ER on a regular basis, and we went about finding a way to solve that problem. Well, we found a way to solve the problem, and we got the frequent flyers out of the ER, only to find out that the way the financial reporting goes is that you can get them out of your ER by case managing them, but then back to the cost of charge ratio, you got to give it all back. And we kept saying, there's got to be a better way to do this. And we know there's a better way to do this. But we didn't have the waiver capability to be able to request that. And that's one of the things that could come out as a result of this particular bill. We think that this is a tremendous opportunity to improve. And we know that there's administration simplification. I want to point out something we got going on over at DCH with Blake and Company that illustrates what can be done here. And that is, there are ways to simplify things, and Blake over at the Department of Community Health has done an excellent job of doing something called administrative simplification. There's all sorts of things that we can do to simplify, and we can't get to it. And the chairman is telling me I'm out. So I want to share with you that this is a good bill, and we think that there's a lot of great things that can come from it, and we strongly encourage all to support that, and we look forward to working with all aspects of the committee. Thank you. Thank you, sir.
All right, folks. Let's limit our conversation to 106, okay? And your feelings about this particular bill, and I know we've had a lot of conversation about a lot of different issues as far as health care, but let's limit our conversation to Senate Bill 106. Ethan James, and then Tom Andrews, and then Deborah Nesbitt.
Mr. Chairman, members of the committee, thank you for the opportunity to comment on SB 106. I'm Ethan James of the Georgia Hospital Association. GHA represents more than 160 hospitals throughout the state of Georgia, from our small rural critical access hospitals up through our large urban healthcare, multi-hospital healthcare systems. I want to echo some of the excellent comments that have been made about the access to care issues here in Georgia, and just comment that more than 1.3 million Georgians are uninsured today. And the vast majority of those are working one or more jobs. These are working poor who need our help. 30,000 of those folks are veterans or spouses of veterans who have served our country honorably and faithfully. The Georgia Hospital Association, our member hospitals, believe that an insured patient is a healthier patient because they get the right care at the right time in the right setting. They don't wait until their illness or injury has exacerbated to the point that it is so severe that they can only seek care in the emergency room. 8 hospitals in Georgia have closed in the last 6 years, and the overwhelming, insurmountable financial challenge that the responsibility of caring for our state's uninsured and underinsured is the underlying factor for the closure of each one of these hospitals. We believe in access to affordable health care insurance for all patients, and that because every patient's health care needs are different, likewise, every state's health care plan will be different, and we support a Medicaid waiver for the state of Georgia. Happy to answer any questions.
Okay, any questions for Mr. James? Seeing none. Thank you, sir.
Thanks, sir.
Tom Andrews and Deborah Nesbitt waiting in the wings.
Mr. Chairman, committee, thank you for allowing me to speak. I don't have any notes. I'm going to speak from the heart because, and probably a little selfishly about the people that we represent. Mercy Care is a federally qualified health center. We serve here in Atlanta about 15,000 patients a year. 85% of them live at or below 100% of the federal poverty guidelines. About 80% of them are homeless, and about another 60% suffer from mental health issues. Back when the ACA, we have 11 clinics. We offer soup to nuts, dental, primary care, innovative behavioral health services, vision services, but we're busting at the seams. We run about a $5 million a year deficit because of the patients that are uninsured. Many years ago when the ACA was passed, I was doing cartwheels down Decatur Street, hoping that the 85% of our patients would be insured through Medicaid expansion. And when the governor decided that that wasn't going to happen because our Medicaid system is broken and it would cost too much, I was not a happy camper. And I will tell you that for many years I continued to be the fighter for Medicaid expansion. And then I'm part of the Grady system. We're joined at the hip. And when we started to study these other waivers that were going on, I really got excited because I could see that our system is broken. I've been in healthcare for 40 years. It's a broken system. We waste so much money. And by just continuing to use the same system to create access to care and good care isn't the way to go. We've got to transform the way we do things, and the waivers are the way to go. So I'm very supportive, and I really encourage you to push this thing through. Thank you.
Thank you, sir. Anyone have a question? All right, seeing none. Thank you, sir. ACCG.
Yes, sir. Thank you, Mr. Chairman and members of the committee. I'm here representing the Association of County Commissioners. My name's Deborah Nesbitt, and we represent all 159 counties. We want to offer our full support and thanks to the governor for this bill. We hope that it will increase access to health care and behavioral health care services. As you know, we are in a crisis level in many of our communities. So we thank you and applaud you for bringing forth the legislation.
Very good. Thank you, ma'am. Anyone have a question for the lady? Seeing none. Thank you. Jesse Weatherington, excuse me. Jesse Weatherington. And then Kyle Jackson is next.
Thank you, Mr. Chairman, members of the committee. My name is Jesse Weatherington. I'm here today for the Georgia Quality Healthcare Association, as well as the Georgia Association of Health Plans. So together they represent Georgia's Medicaid managed care organizations and the fully insured commercial insurers in Georgia. We are in full support of Senate Bill 106. We would commend the legislation to you and want to applaud the governor and Senator Tillery for bringing this very important piece of legislation, authorizing the administration to pursue an 1115 waiver, which will allow for tailored and innovative approaches to improve the Georgia Medicaid program, as well as the 1332 concept to provide stability to the commercial insurance market. Would be a welcome change for Georgians who are struggling to find affordable health care options. So would fully commend this bill to you, and I appreciate your support. Thank you.
Any questions? Very good. Thank you. Dr. Daniel Langford after Mr. Jackson.
Good morning, Mr. Chairman, or afternoon, members of the committee. I feel like I'm trying to get a bill out of rules today. Appreciate the opportunity to be with you to support Senate Bill 106. I'm Kyle Jackson from the Georgia Chamber of Commerce. This issue has been our #1 legislative priority for the last few years, and we're thrilled to see Governor Kemp lead on this, with Senator Tillery and this body as well. And we would ask for your favorable consideration and be happy to answer any questions.
Oh, okay. Anyone on the committee want a question? Okay, seeing none. Thank you, sir. Dr. Daniel Langford, and Tony West is after him.
Well, I want to thank, first of all, the governor and Senator Tillery for bringing this bill forward, and everybody else that's been working on this bill and everybody on the committee. I'm really glad that we've started this conversation. I hope it's a conversation that continues, and I look forward to being a part of that. My name is Daniel Lanford. I'm a postdoctoral fellow. I've got affiliations at Georgia State and Emory University. My fellowship is funded by the Georgia Scholar Strategy Network. My personal research is on public opinion regarding Medicaid. I've also published with the former president of the American Sociological Association on the politics of ACA and Medicaid. Right now writing a book with other Medicaid scholars across the country. I just came today as an individual, an independent researcher, and a concerned citizen of Georgia, born and raised, to offer my support for this bill with amendments. I think that there are different things that could change with this bill, I hope, and I hope that we'll be able to see that yet, or at least be able to talk about these things as we move forward. First of all, with Section 2.1, I want to sort of echo, I guess, without too much redundancy, what other people have said about the coverage gap. If we leave line 22 at 100% rather than 138%, we're putting Georgia at risk, I believe, I fear, first of all, of paying more and getting less, right? I know there's been talk at the federal level about perhaps expanding what the federal subsidy would be even to states that do other things. My experience as a researcher has taught me one thing, is that this is a sticky bill, and there's not a whole lot of a guarantee from the federal government that change is going to be there. So one of the things we want is to have the flexibility that we need in Georgia to make the best situation, whether that's leaving out the 100% or adding 138%. I think it's important that we put ourselves in a position where we can raise that limit if we need to, and give ourselves that option, give Governor Kemp that option. Right, even if that we do have the subsidy and we're not paying exorbitantly more, we're still going to be leaving those people out to dry, I fear. There are the issues with the co-pays, the deductibles that I think we're all familiar with from our own insurance experiences that you start dealing with if you go into the individual market on the exchanges rather than having the Medicaid cover that area significantly more efficiently. All right, so I just want to stand with everybody else that supported a change there, if there's any way we can make that happen, and perhaps now or in the future. I also want to speak to the second section of SB 106, section 3.2. Another amendment is needed. Currently, the bill leaves open the possibility of a number of waivers that some people will hope bring down the price of private insurance plans. However, some of these, it says any waiver, right? There are no guardrails in this part of the legislation, and that concerns me. Perhaps as an academic, I want to know information, and there's a lot of information out there without guardrails. There are some potentially good things that could happen. For example, a reinsurance program could help stabilize the insurance market, bring down costs. If the subsidies that Georgia pays to insurers are passed on to consumers in the form of lower premiums, co-pays, and deductibles. However, it also opens the possibility of things like eliminating essential benefits, and I know we've talked about the fact that hopefully we're not going to get rid of pre-existing conditions, protections, and those kind of things, but this bill leaves open, we need to be explicit about this, I think, in the bill. It also leaves open the possibility of differentiating risk pools, which could go well or could not go well. It could end up with some people facing considerably more costs, either with their premiums because they're in high risk or in low risk because they've rolled the dice and they end up getting in trouble in the long run. Thank you. Just because there's when they do get hit with a medical bill, it could be catastrophic. All right, so I suggest we have an amendment there to continue offer the minimum benefits and keep the prices from varying by risk rating. That's about all I have right now. I think we need those two amendments, and if you got any questions, I really appreciate the work that everybody's done, and I look forward to working with you in the future.
Well, thank you, sir. Anybody have a question? Oh, hearing none. Thank you.
Thank you.
Tony West. Wed Gwynn. Davies. Okay.
Thank you, Mr. Chairman, members of the committee. On behalf of Americans for Prosperity activists in Georgia, I'm here to testify in opposition to Senate Bill 106, specifically the section regarding the 1115 waiver. AFP activists engage friends and neighbors on key issues and encourage them to take an active role in building a culture of mutual benefit where people succeed by helping one another. Unfortunately, Medicaid expansion works against this mission because the program reduces health care access for low-income people and encourages them to remain dependent on this failed system. Supporters claim that Medicaid expansion will help new enrollees attain better health care. However, large numbers of newly eligible individuals will receive worse health care as a result of this expansion. Once Medicaid becomes widely available, many low-income workers decide to drop their employer-funded coverage and sign up for Medicaid because it charges almost zero copays, deductibles, or premiums. A study published by Obamacare's primary architect, Jonathan Gruber, found that 60% of all individuals who enroll after Medicaid expands already had private health insurance. Pushing low-income Georgians off private insurance and onto Medicaid would significantly worsen their health care access. Because Medicaid compensates physicians significantly less than private insurance, nearly 30% of Georgia's doctors simply refuse to treat a patient on Medicaid. At a time when Georgia already faces significant doctor shortages, Medicaid expansion would only throw additional barriers in the way of individuals seeking care. Furthermore, Medicaid encourages families to remain on this failed program. Because Medicaid is phased out as an individual's income rises, Medicaid encourages adults to work less and earn less income so that they can stay on the program. According to the White House Council of Economic Advisors, more than half of all able-bodied adults on Medicaid do not work as a result of Medicaid's anti-work incentives. In some states, as many as 70% of Medicaid's able-bodied recipients languish in unemployment. Georgia desperately needs to reforms to provide reliable and affordable health care to our state's poorest residents, but this isn't the answer. For these reasons, we're asking committee members to please vote no. Thank you for your time.
Okay, thank you, sir. Anyone have a question? All right, seeing none, thank you. Is that Gwen Davies? Davies, looks like a DI.
Thank you, committee. My name is Gwen Davies. I'm a psychologist, and I'm the behavioral health director for Positive Impact Health Centers. We see about 2,000 people with HIV, and I'm not a lobbyist of any kind. I'm just not seeing patients so I could see you. And I'm doing that because Medicaid is a life or death issue. I think people will say all kinds of things about the economics, and certainly that matters. But what I have to tell you is that I've seen people die because of their lack of coverage. That's what happens when people don't have access to the health care they need. And that's an interesting problem with HIV because HIV is almost the only disease where if you're a low-income person, you can get coverage. The reason we don't have massive numbers of people dying of HIV anymore is not just because we have good drugs, but because we have drugs that the federal government is paying for and health care the government is paying for. However, we still got 40% of people in Metro Atlanta out of care, people that know that they have HIV, and that's why President Trump has identified these four counties in Metro Atlanta as being part of the worst part of the epidemic. So we are targeted. He's focused on ending the epidemic in the United States, which is a winnable battle. But Medicaid and a waiver really make a massive difference in our ability to fight this epidemic. Because if all of those people came into services, we have flat funding from the federal government. We don't have any more dollars to serve them. All of the clinics have, you get in, you can't, it's difficult. We're fairly full of people. And this is not that different in the rural areas. There's many rural counties that also have a very high rate of HIV. But if you expand Medicaid, it means that not only will more people live, but fewer people will get HIV. Because if you can get people on treatment, they are not able to transmit the virus no matter what their behavior is. If we can get them in care, if you can get people on PrEP, which is a pill that helps the highest risk people prevent HIV, that could also be paid for by Medicaid. And so that makes just a massive difference. It really is life or death. It's close to my heart. As a mental health professional, it makes a massive difference. I am called in most days to see somebody who is struggling with thoughts of suicide. And I have to make decisions about whether they should go to the hospital. Do you know what it's like to try to go to the hospital if you don't have insurance in this city? And even worse in the rural areas with my colleagues there, it's extremely difficult. If we have Medicaid, we prevent all kinds of death. HIV isn't just one of them, but it's many. So people can talk about the economics, but this is a life or death issue, and I really applaud you for taking it up. Thank you so much.
Thank you. Becky Rawls? And then Debbie Buckner's after. Becky?
Thank you, Mr. Chairman, members of the committee. I'm Becky Riles, representing the Georgia Primary Care Association. GPCA is the member service organization for all the community health centers in Georgia. You've already heard about the FQHCs. For those of you who are still wondering what FQHC stands for, it's a federally qualified health center, which means they receive a federal grant to allow them to take care of those who are underinsured and uninsured. Access to health care is available at a community health center for those who have insurance, those who are the working poor, and those who have no insurance at all. For those who have no insurance, the payment is given on a sliding fee scale. So they're charged according to their income verified rate, and that is the fee that they're charged on that sliding fee scale. Community health centers are locally governed. They are 501c3s. There are 35 organizations in Georgia and 225 clinical sites. The mission of health centers for over 50 years has been to provide primary care, access to a medical home for preventive and primary care, and case management for chronic disease conditions such as diabetes, hypertension, cardiovascular, many of which you've heard about today. Community health centers appreciate the leadership of Governor Kemp, Senator Tillery, and Mr. Chairman and members of this committee for your leadership in bringing this forward. And we stand ready as community health centers in Georgia to continue providing access and expanding access to primary care, as well as working with our community partners, other physician groups, hospitals, to improve the quality and health status of all Georgians. Thank you.
Oh. Thank you, ma'am. They do a wonderful job. Okay, Debbie Buckner.
Thank you, Mr. Chairman. Ladies and gentlemen of the committee, I appreciate you listening to me. This is a topic that's very near and dear to my heart. I've worked in public health for 35 years, and there were 5 of us that met, and we had over 150 years experience, and we talked about this bill and about waivers and about Medicaid expansion. And what we came together with that has to do directly with the bill is that we are concerned about the lack of structure and guardrails, as somebody said earlier, in this bill to address the health care coverage gap and how we could improve coverage in a way to help our rural hospitals. We drafted a bill and we drafted amendments and we talked to people, and we understand, not being on the committee, we weren't in the position to do anything other than talk today. And I'd like to have a conversation to tell you that we need something to cover the gap. And one of the ideas that we talked about was how well Peach Care for Kids has covered the gap for covering children. It is a program where children are covered for health care needs. There is a sliding scale for people to pay part of the bill, and it is a successful program that is all across the state. So we applied those same thought processes to a Peach Care for adults. And the idea was that we could establish a program that would take care of people 19 to 64 that are not covered. That this would become an income-based sliding scale program where people, as many people have said to me, that would have skin in the game. They would be investing in their own health. We talked about some special features that needed to be in the coverage plan of this type, such as the fact that we are 49th in the United States in maternal death, that maybe we could make sure instead of the Medicaid we have now that only covers 6 weeks could be expanded to the first year that would cover that time period when most of the women are dying at 6 to 8 months after delivery. We also talked about the terrible immunization rate for our adults and that maybe all immunizations could be covered in this Peach Care for adults. What I'm telling you with all of this is that Peach Care for adults or some kind of program of this type would give what rural hospitals need to stay open, an infusion of cash. It would give what doctors that are going to our medical schools where we've increased the enrollment the opportunity to do, and that is go into communities because there'd be an infusion of payment system for them to be seen. Many of the insurance companies across the country in the exchange are not known to people outside of very small areas, but Medicaid is known, and a program such as Peach Care for Adults that would be a Medicaid-based program would be known in those communities and would be usable. I've long been a proponent for Medicaid expansion, and I know some of you well enough to say she's just trying to push Medicaid expansion, and I am a proponent of that, and you can say that if you want. But more important, I've been an advocate over the years for us to find a way to be, and I've been a supporter of Peach Care for Kids ever since its beginning, so I'll go ahead and put that on the record too, so to speak. But more importantly, I have worked for years as an advocate for quality health care that's cost effective. I've worked in public health, I've worked for a for-profit hospital, and I've worked for a not-for-profit hospital. And I've seen how the model works. And what I think is interesting for all of us in this bill that is very nerve-wracking and very scary to me, and no offense because I really like the author lots, but on line 22, the 100% of federal poverty level being the maximum is problematic. If you think about if you had no other income but your legislative income, at 100% poverty level, you would be in the gap. You would not be able to afford anything. You would be in the gap if that was your only income. We are putting a lot of people in harm's way because we don't have opportunities out there that are easy for them to access. And people say, well, let them go to the exchange. The exchange would cost more for them as an individual than a program such as a Peach Care for Adults. I'm just going to say in closing, Georgia, since the 30s, when they were one of the first states to have a state Department of Public Health, has had innovative health care programs. We've never been one to sit back and say we're satisfied with being 49th in any group dying. And we shouldn't start now. We should be dedicated to become a leader in public health. We should be dedicated to be, just like we've been in the past, out there in front and innovative. And I don't think that having this be so wide open and having the third thing in this bill that concerns me is line 23, 24, and 25, where it says the department shall be authorized to take all necessary steps to implement the terms and conditions of the waiver without any further legislative action. I'm sorry, ladies and gentlemen, but I am just really concerned about us not being involved in helping our health care system that we've all said today is broken, not have more input from us than that. And with that, I'd rather yield the will. Thank you.
All right, thank you, ma'am. All right. Emily Yona? Georgia Dental Association?
Thank you to Chairman Smith and the committee for allowing me to speak today. My name is Emily and I'm the Director of Health Policy for the Georgia Dental Association. Today I'm here to ask this body just to keep dental care in mind while we're having these discussions with the governor's office and while this bill is being proposed on the floor. Thank you to Governor Kemp and Senator Tillery and also to Representative Lott for bringing the legislation. It's something we definitely want to be part of the conversation. Currently, Medicaid in Georgia only covers comprehensive dental care for children and pregnant women. The only dental procedure that is covered for non-pregnant adults is emergency extractions, including adults with developmental disabilities. That's the part of the conversation that we'd like to be a part of. We have tried to come up with solutions to get access to dental care for adults, including the Georgia Mission of Mercy, but we'd like to look forward to sustainable ways to continue to get dental care for Georgians. I'd be glad to answer any questions. I know we've been here a long time, so I'll keep it brief. Thank you guys so much.
Okay, I see no questions. Thank you, ma'am.
Thank you.
Okay, June Dean, American Lung Association. And then after that, Kyle Wingfield.
Hi, my name is June Dean, and I'm here to speak on behalf of the American Lung Association. I want to thank the committee for their time and attention to this issue. It's real important. The Lung Association, first and foremost, does support expansion of Georgia's Medicaid program to 138% of the federal poverty level. This expansion will help more lung disease patients access the comprehensive health care they need and includes essential health benefits like emergency care and hospitalization. And I'll be brief because I've got a statement in your packet, I believe. But in short, we think Medicaid expansion can do a world of good for Georgia. And again, thank you for the opportunity to offer comments on Senate Bill 106. And we stand ready to help any way we can.
Okay, thank you, ma'am. Anybody have a question for the lady? Seeing none, thank you. Okay, Kyle Wingfield.
Good afternoon, Mr. Chairman, members of the committee. I'm Kyle Wingfield. I'm president of the Georgia Public Policy Foundation. We have long advocated for both types of waivers included in this bill. I'd like to spend my time today talking about the 1332 waiver, in part because a lot of people have been focused on the Medicaid waiver part, and in part because I think the 1332 side can address a lot of the concerns they have about the difference between the 100% and the 138%. One of the reasons that we're talking about the cost of health care on the exchange, health insurance on the exchange, is because the overregulated nature of the plans that are there. What we've seen in recent years is prices soaring, choices decreasing, competition going away in many parts of our state on this vital exchange and market for Georgians. What the Trump administration has done in the past several months is show states how they can act within the framework of the Affordable Care Act to deregulate this market in a way that makes these plans more affordable, that will increase choices on the market, and thereby increase competition and bring down prices. We think that's a very important part of this discussion. For instance, the reinsurance discussion, one of the 4 ways that the Trump administration has outlined as prime ways to restructure the exchange plans. In states that have adopted this, they have seen double-digit percentage decreases in the premiums for their plans. That's a real savings, and that's been done in many states so far. Another provision would allow people to take the subsidies that they're due under the Affordable Care Act, put it in an account similar to a health savings account, spend part of that on the premium, and save the rest to use for their out-of-pocket costs. This gives them an incentive to shop around for the plans that are available. It also gives them money available to cover some of those out-of-pocket costs because those have certainly increased over the last several years in these plans. All told, we think that there is a great opportunity through that type of waiver to drive down prices. The Trump administration has also said that the structure of the subsidies could be changed to the extent that the cost would still be prohibitively high for those at the bottom end of the subsidy range, closer to 100% rather than 400%. The governor could very well restructure those subsidies to help make those people more whole and make sure that the insurance is not too expensive for them. We think that's the kind of innovation that Georgia needs to have a health insurance market by Georgians for Georgians, and that will help eventually help as well with the Medicaid eligible population. So those are the points I wanted to cover in my limited time. I'm happy to answer any questions you may have.
Anyone for a question for the gentleman? Seeing none, thank you, sir. Mike Dudgeon.
Thank you, Mr. Chairman, members of the committee. I'm here on behalf today of Lieutenant Governor Jeff Duncan. When he campaigned for office, health care access and reform were a big part of his platform, and we believe, and Lieutenant Governor believes, that this is a huge first step in that area, that we will both decrease costs and increase access for all of Georgia. I want to point out one interesting thing about doing 1115 and 1332 waivers together allows our state to be a pioneer be able to look at all Georgians from the least number of income all the way up to the ones on the upper end of the income scale with the combination of the waivers, and to do that plan all together. And the fact that a lot have been made today about 100 to 138, but really this plan with this combination will allow the 1332 to address, we believe, the 100 to 138 with a better possibilities than just a plain expansion. And we really appreciate this. Our office has been happy to assist Governor Kemp's office in working on this plan, and we appreciate the House's favorable consideration on this. Thank you.
Well, we got a question from Representative Perkle. Hold on one second. There you go.
Thank you, Mr. Chairman, and thank you for your testimony. And I want to thank you for bringing up that particular point, and for Mr. Wingfield just prior, the importance of 1332 in the same bill with the 1115s, and what that could do for this state. I think we have looked on page 1 of this bill too much and not looked at page 2, and the two of them combined. And thank you for actually putting these together and showing what we could do with market forces in the great state of Georgia.
We totally agree. Thank you.
Thanks, sir. That's all I see.
Thank you.
Representative Bentley, I understand you want to make a comment.
Thank you, Mr. Chairman, and to members of the committee and all of the guests in the audience. I wasn't going to say anything, but when the gentleman spoke about his heart, what was on his heart, I just felt compelled to come and share what's on my heart. And I've listened carefully to everyone who's spoken this afternoon and in previous meetings. I've heard from the Hospital Association, various associations and organizations and groups. But I want you all to hear from a caregiver, somebody who is dealing with health care every single day. And everyone in this room knows my story, so I don't have to repeat it. And you know that I live in a rural community caring for a spouse with a spinal cord injury. And access to health care is very, very limited, my friends. And I struggle every day to give my husband the quality care that he needs. And that's what we have on the table right now, this bill. It may not be the perfect bill, but it's what we have on the table right now. And my friends, I respectfully honor you and very grateful to you how you all have helped me throughout this past year. But this is what we have on the table right now. And I know what I'm dealing with every day. So until you get a chance to walk in my shoes of lifting and turning someone that's 280 pounds every day, then it can be a different story. But what we have on the table right now, my friends, I see as a way to help my area. And so for that, my friends, my colleagues, I respect you, I honor you, but I'm voting for this bill. Thank you, Mr. Chairman.
Thank you, ma'am. Senator Tillery, would you like to make some closing remarks?
Thank you, Mr. Chairman, and I don't know really how you follow up on what Representative Bentley's already said. I do want to address just one or two things I heard the speakers say as they came up here, and thank you for giving everyone members of this committee, thank you for giving everyone an opportunity to be heard today about an issue that we know affects everyone in Georgia, as Representative Bentley so eloquently put it. I heard some of the speakers address access. I heard one speaker say that 30% of providers don't take Medicaid. That's higher than the number I've heard. But it is a true answer to the question about why putting a card in someone's pocket isn't necessarily giving them access. I heard folks address a gap, and there is a gap. They are correct, but I think their numbers are wrong on where that gap is. That gap is to 100% of the poverty line. Once we hit 100% of the poverty line, the subsidies that are offered under the Affordable Care Act pick up. To take and expand to 138% would actually force people who are eligible for subsidies now, sometimes to the tune of 97% of a health care insurance policy. It would force them to not be able to buy a private health care insurance plan and force them onto a government-run Medicaid plan. I think the governor has been painstaking in his detail in this matter. He has tried to make sure this bill doesn't just address those who are rich, it doesn't just address those who are poor, and it doesn't just address those who are in the middle. We could expand Medicaid. We could buy the suit off the rack, like many states have done. And they've come back after buying that suit on the rack, and they've tried to tailor that back down. They've tried to ratchet it down. We've seen that in Indiana and Arkansas, and I believe in Massachusetts. But our governor's done it differently. He said, let's take and apply Georgia solutions to a Georgia problem for hardworking Georgians. Let's tailor that suit off the rack rather than putting it on and trying to come back and cut it later. Thank you so much again, Mr. Chairman, for allowing this bill to come before your committee. Members of the committee, thank you so much for the time that you've put and the energy you've put into listening today. I appreciate it.
Thank you, sir. Chairman Parrish would like to make a comment.
Thank you, Mr. Chairman. I just wanted to make a couple of comments here before we wrap this up. A few of us are old enough to remember when Medicaid came into existence, and some of you in this room were not born then, some 50 years ago. And during that time, of course, there have been some changes, but what we're looking at here today is with waivers is to allow us to have the opportunity to tweak a program, to make some changes, to improve that program. And certainly, I think most of you would agree with me, this is not the end all. It's really just the beginning of where we need to go. And I want to make a comment, too. I think the members of the legislature, and especially this House, can take a lot of pride in the things that we have done in the past few years to help improve access to health care in this state. We have been a part of increasing the number of residency programs around this state. We have residency programs now all across the state in many areas that we've never had before to train our doctors. And these doctors that are going to come out of training, we hope they're going to remain in some of these areas, especially in a lot of our rural areas. Somebody mentioned earlier today about the maternal mortality. If you think about the budget that we passed that left this House, that was a program that many had a lot of interest in, and we made a lot of changes and put money in there to help fight that very same problem. So I think there's just a lot of things that we have done that we can be proud of. And another thing was mentioned today, just because you have a card that says you have coverage, if you don't have a provider out there to provide that coverage for you, how much better off are you really? We've got to make sure that the providers in this state who provide services to people on these programs are reimbursed at a reasonable rate for the service that they provide. If there are no providers out there, we're no better off. I'm going to support Senate Bill 106. I think it's certainly a step in the right direction. It's not the end all of where we need to be, but I really think we're making a step in that direction, and I hope that the other colleagues on this committee will do the same thing. Thank you, Mr. Chairman.
Thank you, sir. I agree with you. Health care is going to be an issue for a long time because we've got a lot of issues out there where it's prenatal care or maternal deaths or not having doctors. So we've got a lot of issues that we're going to have to address, and I think it's going to be a continuing process, and I don't think it'll ever end because it'll change continuously. Okay, Chairman Hatchett.
Mr. Chairman, at the appropriate time, I'd like to make a motion.
Well, unless I see someone else with a light on, I guess it's the appropriate time.
I'd like to make a motion to do pass Senate Bill 106.
Okay, we got a motion and a second. All in favor say aye.
Aye.
All opposed like sign. Okay, let's raise our hands. All in favor say, raise your right hand. Okay, all opposed? Okay, motion carried. Thank y'all. Senator, don't forget to go by rules. Okay, thank you. Y'all have a great day. Thank you.
That's okay. You're expanding that. You're leaving blood on the field already. You got first dibs on anything.